Thank you. Thank you, Dr. Manish. After comments from the chairpersons, there can be questions from the audience. Maybe first we'll have any doubts to be cleared in performance or measuring the AV flow. Thank you. Thank you, Dr. Ajay. I think you did a great job, impressing on why the diameter is important because it is required in the formula. And it is better to do it without the color because the color can sometimes be exuberant and it can overshoot the real diameter. So you measure the diameter in the black and white even beforehand, before you put on the power Doppler. And I think he has been very clear. And one small.
Hey Ajay, this is Adrian. Great presentation. I loved it. The only other thing that I would add is whenever we look at the artery, one of the things that we do here is we move the probe up, along the artery towards the axilla, just to see if there's a high bifurcation of the artery, because we cannot go by the op nodes. I remember Adil Beg once presented a case of an axillary brachial artery where the flow was poor, and nobody even looked into whether this was an axillary brachial artery. So one of the things that you can also do when you do your ultrasound is just move the probe up towards the axilla to see whether this brachial artery is is it a brachial artery, is it an axillary brachial artery, or is this a high bifurcation of the brachial artery resulting in a radiocephalic fistula. The last thing I wanted to ask was, I tried to do these measurements and everything what you said I followed to the T, and yet I would just get different flow measurements varying from 1,000 to 2,000, and then I left scratching my head. And I end up again looking at the artery. Sometimes the same problems happen. So I don't know if you have the same experience.
Yeah, sir, it's a very valid point. So I think, yeah, we should definitely rule out a high branching brachial artery. As far as the variation in the blood flow measurement, yeah, it is there. No, because it is so much technical dependence, and even a slight variation in the angle with which you are focusing on the artery will actually result in a different flow, and especially when we take the inner diameter, whether we are taking during the systole or the diastole, that itself will actually result in a very big difference in the flow. I think if we can actually get the correct acute angle of insonation and keep it always fixed on 60 degree and measure the diameter of the artery in the short axis mode, I think that helps a bit. But yeah, some variation will always be there. It will not always be concurrent, right? 1,000, 1,000, 1,000. It doesn't comes like that. That is there. So it's complementary to other evaluation. I think using it as a standalone may not be that useful.
Right. I think some people in this country, at least in the United States, they use these probes that are within the vessel and they get a flow reading. I don't know how accurate that is over ultrasound.
Are you talking about transonic, sir?
Yeah.
Okay.
Ajay?
Dr. Ajay, I had one more point. The measurements, what you have mentioned and all those things. In a few machines, there is one option of choosing the probe setting as arterial mode. You go into arterial mode and then you have an option of measuring transarterial pressure, wherein you just have to feed the arterial diameter, and then you take those three waveforms. It automatically calculates and gives the reading for you. So are you familiar with that technique?
Yeah, I think that's what he also mentioned, Girish. The last, you take the arterial diameter. Yes,
no, but this is
yes, I think we have to take
the probe setting. He's talking about a probe setting, because what Ajay showed was the just linear Doppler that all of us use, but Girish is telling something else.
So basically, we have a sonocyte machine with us. In that sonocyte machine, what we do is sometimes it can be confusing, because at the beginning itself, we have to choose the probe setting as arterial setting. And then once we do that, then we have an option of measuring transarterial pressure, wherein it gives a volumetric flow of mils per minute. So that's what I was trying to mention, Dr. Ajay. Do you use the same kind?
So I think in all the machines which are available, when you choose the probe and then you go for Doppler, it will ask you what kind of Doppler you are doing. And there are always an option of whether you're doing an upper extremity, arterial upper extremity, venous, carotid, and something like that. So in that, we generally choose upper extremity arterial. But our trans-arterial, I don't understand. Like, it's an invasive or a non-invasive way?
No,
Because
non-invasive. There is an option called TAP, trans-arterial pressure, wherein it gives mils per minute flow measurements.
So this is okay. So this is also giving ml per minute. So initially, when you are doing this Doppler's analysis of that spectral analysis, it is telling you the time averaged mean velocity. And then as soon as you enter the diameter, it will do all the multiplication and give you the calculation in ml per minute.
Yeah.
So is there a difference?
So we are also using Girish, what you have mentioned is TAP or transarterial pressure.
Yes.
This sonocyte, because this is by default. Whenever you switch to vascular mode, this linear, this will automatically come into that mode only. Like you were saying, you have to select arterial mode. I think for us, they have made a setting that automatically it comes into that mode only. We just have to measure the diameter and then assess the Doppler waveform, and then we select the waves, and it automatically gives us the flow.
One more doubt I had, Dr. Ajay. Would it make sense to measure the flow at the cephalic arch? Because ultimately, when we are deciding on an high flow fistula, probably the flow at the cephalic arch or flow into the subclavian vein is probably what that matters for us. So would it make sense to measure flow at that point?
Yeah. So I think TAP is, I think, time averaged peak velocities, which it is measuring, and then it is trying to find out the flow. And generally, when you use TAP, flow is going to be higher than when you actually use time averaged mean velocities. So I think different companies which make machine do their own correlation, which one fits better with the real volumetric analysis according to them, and then they use that formula. So for GE and Philips, they are mostly using time average mean velocity, while for Sonocyte and I think Toshiba also, they are using TAP as the flow velocity for calculating the formula. As far as cephalic arch is considered, I think before the flow actually reaches the cephalic arch, there will be many tributaries, and there will be collaterals also, and the flow will be directed. So looking at it will be interesting, but if so many of them will be having cephalic arch stenosis also, that will also be affecting the flow through it. So we'll have to see.
Ajay, how close or far from the anastomosis you make the measurements?
So for arterial side, generally we use 5 centimeters or so proximal to the anastomosis, so that there is no turbulence because of the anastomosis and we get a laminar flow. And for the venous side, we assume that say 10 centimeters or more from the anastomosis. But I think these are not absolute figures. You can examine the fistula on color Doppler and see how it is coming, how much turbulence is there. And according to that, you can decide which is the best site to measure the flow.
We don't measure it in vein because we found it to be erroneously high as compared to artery, because vein can be usually dilated also. Even a long segment can be dilated inappropriately. So that is what I have found, that venous usually gives a higher value as compared to your arterial flow, and that is why we are always assuming this, calculating it in brachial artery.
Yeah. Nowadays, brachial artery flow measurement has sort of become as the standard which we do for AV fistula flow measurements.
And for radiocephalic also, you prefer brachial artery, right?
Yes. For radiocephalic also, we'll be doing brachial artery flow measurements.
Yeah, this measurement becomes important not only for high flow AVFs to assess the success of, the chances of good maturation and all that. People sort of keep measuring this flow early in the post creation time and try to predict, isn't it, Manish? I remember you mentioning this in the meeting there.
Regarding what, sir? Regarding measurement of flow?
Preemptively, like 1 week after creation, 2 weeks, 3 weeks.
Yeah.
And whether
so at that time, what I was saying is that if you want to cannulate the fistula, early cannulation of fistula, I was telling in that reference that especially there is data from Japan that what they are doing, that once they have made fistula, they do a weekly kind of assessment for flow as well as for the venous diameter. And what they have said is that if your vein diameter is 4 millimeter and if your flow is 400 milliliter, then your fistula is ready for puncture. Because this rule of 6 is there. We all follow this rule of 6. But what those people have shown you that if you follow this 400 mils and 4 millimeter of diameter, then you can cannulate your fistula at an earlier stage. And they have also shown that this earlier cannulation of fistula is not associated with significant complications like thrombosis or whatever in comparison to your usual function.
Manish, can you explain the physiology of recirculation which happens in high flow fistulas in IVs?
Yeah. So what I was saying,
And
there are
inadequate
kind of
hemodialysis.
yeah. So there will be two kind of recirculation. One will be because of if there is associated stenosis, there will be excess recirculation, which we are familiar with, that blood is not going, but the same blood is coming back and the same blood is going into dialysis. This is what is known as excess recirculation. But what we often ignore is cardiopulmonary recirculation. So what happens in high flow fistula? Suppose your cardiac output is 5 liters and your fistula flow is 2 liters or 2.5 liters. So your ratio becomes somewhere around 50% or 40%. So what will happen is that 40% of whatever your cardiac output is going into fistula. So which should be less than 20%, and remaining 80% should go normally to the remaining body parts. And the blood which is going to remaining body part will collect the uremic toxin and bring it back to the circulation, right? And this is how a dialysis, then your dialysis membrane will remove those toxins. What will happen in high flow fistula is that significant amount of this cardiac output is going into the fistula without going into the other body parts, and so the uremic toxins will not be collected from other body parts, and the same blood which has already been purified, 50% of that blood is again coming back to the dialysis machine. So this is cardiopulmonary recirculation. So in high flow fistula, both kind of recirculation occurs, the excess recirculation as well as cardiopulmonary recirculation occurs in high flow fistula, and that is why significant percent of these patients will present with inadequate dialysis.
Right. Then could someone, could someone, yes, sir, Kashi, sir.
Manish, Dr. Kashi here. I have a doubt.
Yes, sir.
You are muted, sir.
You are using 3-0 silk for the suturing, isn't it? Now, is there a chance that this will cut through the vein when you tight it very tight? I am asking about a theoretical possibility.
No. We are using 3-0 proline suture, and this does not cut through the vein.
Okay. Not immediately. What professor asks is over time, can that?
No, it has not been reported. It will not cut through.
Okay. Coming to the interesting part. Yes, sir.
Just with Ajay again, and Dr. Rathi, you all said that when you use the reading with transarterial pressure, those readings are higher than the usual one that we get TAM. Is that what you said?
No. I'm not saying that. What I was saying is that if you are assessing your flow on venous segment, then it is usually high as compared to the arterial segment.
Okay.
I think
but there is
no arterial pressure. I think both are arterial pressure. TAP is, I think, time averaged peak velocity when it is using. Then it is TAP. Instead of using time averaged mean velocity, it is using time averaged peak velocity. So
I see.
I think it will vary from machine to machine.
To machine.
So they do their own analysis, which one suits, matches, coincides better with the real volume, and in the experiments they do, and then they decide whether to use TAP or whether to use time averaged mean velocity. But in studies in carotid artery flow, they have found that sometimes when you use TAP, it shows erroneously higher flow compared to when you use time averaged mean velocity, but the difference is not very huge. So GE machines and Philips, I think, both use time averaged mean velocities.
Dr. Madraki wants to, sir, please.
Yes. Question to Dr. Ajay and this one. Like whatever we are seeing, like sir presented case, and what we see in our practice is when patient comes with all tortuous veins or cardiac failure, we think of high output failure, high output fistulas. Is there any recommendation that after creation of fistula in our dialysis unit, and like periodically should we measure blood flow, and if so, when we should measure and when we can intervene early, like preemptive, to prevent this tortuosity of the vein and then high output cardiac effects. Most of these veins, what we are seeing high out, like high AVF outputs, we are diagnosing when they come with tortuous veins.
So what is recommended is that you should do your fistula examination ideally every dialysis session, but at least on a monthly basis. And the ultrasound should be done on a 3-monthly basis. And ultrasound examination includes your flow assessment in addition to other things also, like whether there is any stenosis or whatever. So a complete ultrasound assessment 3-monthly, that is what is recommendation by the guidelines, and a physical examination on a monthly basis. So, but the second part of your question is not answered by any literature, that if you find a high flow fistula, suppose you find a fistula flow of 1.5 liter and patient does not have any symptoms, you have picked it up early by your monitoring and surveillance, should you intervene? But there is no recommendation as of now, because whatever way you will intervene, all these procedures have a high chances of recurrence. So if you have intervened at an early stage, thinking that you will prevent the future complications, then there is no data about this, because this will ultimately lead to recurrence, and by the time you will notice, this will again be having a high flow fistula and patient will land into complications. So intervening at an asymptomatic stage is not recommended.
Just to
with all senior permission, may I just add a point with everyone's permission? Ravi sir, one way probably to look at it is all brachiocephalic fistulas should be on high alert. First point. Second point is having a look at the venous pressures. Once we start cannulating the brachiocephalic fistulas, have a look at the venous pressures. Probably that gives us an evidence. Whenever the venous pressure is high, that is the first indication that cephalic arch stenosis has begun to set in. So we have a very narrow window for intervening. Before this cephalic arch has caused clinically significant dilatation of the fistula, probably at that point, if we can intervene and also consider the flow reduction, that may be the ideal point to pick up the things. Once venous pressure is high and the dilatation has set in, probably then the chances of us succeeding in salvaging the fistula and also avoiding recirculation may go down. So that's the way I look at it. Adrian, sir.
I don't know, whether we can, I don't know in this country whether I can just apply a marginally high venous pressure and everything else is good. I don't know. I don't know the answer to that. But it's a good thought, but I don't know.
Yeah.
I think we have to take on dialysis.
Yes.
Vandana ma'am wants to add something.
Yeah.
Yes,
I was going to add something about the question about high out. So I'm going to take off my mask for a minute. But the question about the high output failure and how often you do that, the main thing that I think that we need to do is, you can get an idea or an assessment of a high output state just by a clear physical examination. So when these patients are presenting with a high output state, most of them have a baseline tachycardia. And if you occlude the access, if you're actually, these are huge fistulas, so it's hard to occlude, but if you can occlude them and use a tourniquet and manual pressure, even if it's just briefly, you'll actually see if this patient is, if that high output state is significant, that baseline tachycardia will come down by 10 or 15 or 20 beats a minute. And if you can decrease the pressure on the heart because of your occlusion, if you're actually able to show that, it's called the Nicola-Dani-Branheim sign. Yeah, so if you can do that, that gives you at least some idea whether that high output state is causing a problem. And then, you have studies that have actually shown that when you occlude or when you get, whether you band or you do a Rudy or you do a Miller or you do the endoluminal assisted, whatever you do to decrease the flow, those parameters, left atrial pressure, left ventricular pressure, right ventricular pressure, even pulmonary hypertension, small studies have shown that you do have a positive impact on those. So I think that, the question was whether we should be following these patients. And here our protocol is, we used to do transonics and surveillance, but now we don't do that anymore. We just do monitoring. And if we suspect an access flow, some people recommend even doing an echo every 6 months and trying to make sure. But again, there's no recommendation or guideline for that.
So I just want to add to what Vandana said. This NB sign will not be there if it is autonomic neuropathy or if you have advanced heart failure, because the baroreceptors fail when you have advanced cardiac failure. That's the first thing. The second thing, many of times you will notice actually this happening when you have a stenosis in a high flow fistula and you just put a balloon and you just check somebody's pulse rate, it will just drop. And sometimes that goes really low. Try it out and you'll see. And that scares you on the table. What did I just do? Because the nurse will tell you the heart rate has just dropped to 50 for no reason. And that's because you just put a balloon and inflated everything. The other thing I wanted to ask Dr. Rathi about, he said reasons why flow increases. One of the things that we have noticed is the amount of fluid the patient drinks. If you are doing UF of 5 to 6 liters on a patient, well, we find that those patients end up in high output failure because the volume is so large. I don't know whether you've noticed something like that.
No, personally speaking, we have not noticed like that, because of, theoretically, it is possible that because they are having hypervolemia, and because of hypervolemia, they are having that. Another problem is it is always, I would not say always, but sometimes it is very difficult to judge also that how much they are drinking, because most of our patients are on 2 per week dialysis, and we say that they are already an inadequate kind of dialysis. So they do drink a lot of water. So this may be a possible explanation also.
So let's take this important point. Is it only the flow volume which matters, or any of the effects on the cardiovascular system and other complications which matter before making a decision of handling or managing this high flow?
I don't think we have an answer to that, because if you had heart failure, you would jump on it. If the patient doesn't have heart failure or anything like that, he's not going to come to your attention, because all the symptoms that we're talking about of heart failure also happen with volume overload. And our first response is, let's go and pull off the fluid. It's only when we have pulled off fluid repeatedly that we find there's no anemia, nothing. Why is this patient short of breath? That we look at the AV fistula. And that brings me to another point which Dr. Rathi mentioned about, this banding. I have seen fistulas which are aneurysmal just off, fistulas aneurysmal just coming off the anastomosis with the artery. In those places, I cannot put a band at all. I'll just dig and I cannot find where the fistula is ending and the soft tissue is starting. And so in all the pictures that we see, whether it's in the book or Dr. Rathi's, you can classically see, this junctor segment is nice and thin. You can put the Kelly under it and you can get the sutures across. But once I did something in a patient that was really, it was about 2 to 3, maybe 4 centimeters just beyond the arterial anastomosis. And I just dug like a fool and I couldn't find anything and I had to just stop. And that was a learning point for me, that unless you can get a good landing zone to put those sutures, you should not be digging into those areas. What do you say, Dr. Rathi? What do you think?
Yeah, absolutely agree. And that is what I have also said, that there will be, because they are long standing fistula, one is the dilatation and second is there will be a lot of fibrosis also around the fistula, around the venous segment. So you will have a tough time negotiating that fibrosis. And sometimes what I have also observed, that you will have a tough time negotiating or differentiating where is the fibrosis and where is the venous wall, because you really want, on one hand, you want venous wall to be clean, because otherwise this sutures will slip. So you want to get rid of this fibrosis as much as possible, but you will not be able to delineate where this fibrosis is ending and where the venous wall is starting. So you are absolutely right, and this will, I think this will come with experience only, like our surgeons get experience doing so many cases. So if we start doing more and more cases, so it is unfortunate that you landed up into this situation in your very first case. Maybe you can start with a simpler case, which are not that big or that fibrotic to begin with, and gain some some confidence. That is all what is required.
So not that much indicated also.
Yeah.
The other thing we should also remember is, once we do this procedure and band, we have to be careful about complications that can happen after the blanding. And what I mean by this is the blood pressures will go up. And two, you can precipitate heart failure because you have now decreased the preload to the heart. So something to bear in mind. In fact, at this time, so ASDI, and there's an abstract showing the EF just dropped to 40% when the patient was totally asymptomatic after they banded something. So I just want you to bring this to your attention. We should not forget complications can happen after banding.
Yeah, that is why this original question Dr. Bala asked is very important. That suppose you are doing regular monitoring or surveillance by using ultrasound, say 3 monthly or 6 monthly, and you find a patient who is having fistula flow of 1 liter, 1.5 liter, 1.8 liter. But patient is absolutely asymptomatic. You have done echo study also, and whatever patient is absolutely asymptomatic, but by definition, this patient is a high flow fistula. Will you intervene? Will you intervene in this stage? According to me, there is not enough data to intervene because of one, the complication which you have said, and second is all these, whatever intervention you will do will have a recurrence rate. So they are not the permanent solution also. So you will not be able to prevent the complication, that is, or the symptoms of the patient. That is what I feel. Maybe others can also share their.
So I also share the same concern what you said. By doing periodic surveillance, even if you catch the problem early, unless the patient is symptomatic, when do you intervene? And all these procedures, maybe after the intervention or after banding, that early high flow fistula, you may actually cause a low flow fistula, and the fistula might fail. So only I think after the symptoms come, we have to intervene. Otherwise, catching them early, these procedures I think can't be done. Sir.
Vineet, the way we can look at it is, the moment you see that this fistula is at risk for going for high flow fistulas and future complications, probably from a different perspective, we can start preparing the other limb veins for creating a new axis, new distal axis. So we may not be able to salvage this axis or prevent the complications, but probably at this period, probably we can start looking at creating a distal more axis and start preparing ourselves for distal axis creation. That way we can mitigate these issues.
Course, that way, of course, we can.
Yes.
Yeah, but another thing is not all the high flow fistula will land into complication. That is also important to remember, that you may, because the compliance of the system gets accommodative in those patients, so they will not land into complication. Their heart will be accommodative, their venous system will be accommodative. So you may be observant that now you have observed that this is a high flow fistula. You will be more careful in assessing his inadequacy of dialysis or whatever complication. But whether to intervene, or like Girish, you have said that you should start preparing for another fistula, I think this will be a too far-fetched kind of thing, because you don't know whether this patient will go into complication, whether this patient will require another access or not. Because first this patient has to go into some kind of complication. Then there are ways to deal with this high flow fistula. Then only if you have failed, then you will go to another kind of fistula. So I just wanted to make a point that not all high flow fistula will go into complication requiring intervention.
Okay, I think after Rajarajan's comment, we'll shift gears and go to another area, which will be even more interesting. Rajarajan, you wanted to?
Thank you, sir. Thank you, sir. Excellent. First of all, congratulations to the speakers for their excellent presentation. And one question to Dr. Ajay. Actually, in a vascular mapping, the surface temperature and surrounding temperature is very important in doing a Doppler scanning. So, same, is it whole good for measuring the blood flow volume? So the temperature should be matched with the room temperature, should be brought to a stable one, not a cooler temperature. And gel, sometimes the gel should not be as much cold. So is that whole good for assessing the blood flow volume?
Yes, I think for assessing the vascular, otherwise also we should have a warm, comfortable room temperature. I think that is important. The other things which sometimes affects is the blood pressure of the patient. Even blood pressure of the patient can have some effects and can produce variability in the blood flow volume measurements which we do. So there are many minor factors which are also there which affect these things.
So I think there is some question from chat box. Actually, Dr. Manish Lalwani want to ask question to Dr. Ajay. Actually, I saw in the chat box.
Sir, I have asked that question and he replied in the message.
Fine.
That was a
right. The next thing is high flow fistula causing distal stenosis. I mean central vein stenosis, and central vein stenosis causing high flow. So
Ravindra sir wanted to make some remarks. Ravi sir. Sir, unmute yourself, sir.
All these high flow fistulas that have stenosis, central vein, like I think I had shared with you, few cases I have, and like it was very tortuous, big veins. That is why, like that time I was asking, like the patient was like so big veins, he was not willing to continue after dialysis, and that fistula and cardiac issue didn't settle even after flow reduction, and I was forced to do a right hand distal fistula and close that fistula. And second is like we go very close to the anastomotic site when we are doing brachiocephalic, like flow reduction. Sometimes it is very torrential bleeding, very dangerous. What I use is like inflation device, what orthopedician and vascular surgeons use for tourniquet. Like I just put and keep it, not inflate this one. And once the procedure is over, we just remove it off. If any untoward like bleeding starts, just we can inflate it and close with a Prolene. And that can prevent, especially when we are beginners. We are nephrologists, we are not surgeons. I think all OTs we have that inflation device with tourniquet belt. And that is the most safest because it is a very high flow. Even little nick on the vein or when we are doing dissection, if starts bleeding, it will be a torrential and it makes us panic. I think I use inflation device tourniquet. And second is, can you use Mersilk? Because Prolene again is very sharp. Kashi Vishwasan sir told that there is some chance that this one, and cost wise, Dr. Rathi sir, like I use Mersilk. Is there any this one?
I'll just also add to that. I'll also add to that concern, sir. After hearing you in Avatar, I did this procedure on 2 patients. So first one I used Prolene. Second one I was actually scared that it might cut through. So then I used CV suture, which is a better version of silk. So can we use other sutures also? What do you feel, sir?
No, I'm not very sure because you know, if you want to give a evidence-based answer to this, there will be no evidence-based. So it will be only experience-based. So I don't have any experience with use of silk suture. So if Dr. Ravindran or other people are using silk suture, they can share their experience. But as of now, whatever 16, 17 procedure I have done, I have used only Prolene suture. So I think you can use Mersil. The idea is to reduce the vein segment by whatever means, and it should be a long-lasting kind of thing. It should not get dissolved. Like you should not use those kind of suture. I think that is it.
I think the problem which can happen with Mersilk is that it will lose its tensile strength over next few weeks, and then banding may get loosened up. Prolene generally retains its strength for a far longer period. I think that can be one of the differences which can.
In that, because my patient has a recurrence very early, I'll show if the time permits the images.
Yes.
Ravi sir, just one final remark. One final request. What is the percentage of radiocephalic fistulas and brachiocephalic fistulas in your unit, Ravi sir?
The high flow fistulas, no?
No, sir. As such, the incidence, like your creation of fistulas, proximal and distal.
Proximal is less than 10%. And 90%
of them are radiocephalics.
Radiocephalic and then ulnar basilic. Then I go to proximal.
Bala sir, your percentage.
Yeah, if only I'm struck, without any options beyond the forearm, then only I take a brachiocephalic. Unlike surgeons who try to jump and do it at brachiocephalic in the first instance, because the results are better and failure rates are less. But somehow I'm not for it.
Oh, thank you, sir.
Yeah. So I think I'll very briefly show this case, which I put it in the Inform group recently. and try to get some message or answer for this problem. So this is a 60-year-old lady on dialysis, and she developed edema of the, it's a brachiocephalic fistula and more of forearm swelling and less of arm swelling. And I took her for angio study. Yeah, so it was not a regular cath lab work. It was in the cath lab, but just with the fistula needle in the regular site, we injected, and this is the picture I got. And see here, what I found was the cephalic opening into the vein was gaping actually. It wasn't constricted at all. Then another thing is, in the angio, there was no collaterals at all. Usually, it's such a apparent stenosis, you would expect, plenty of collaterals, garland-like areas. That was not happening. And also, I was wondering whether it could be, end on you or, something, and it was a pseudo, stricture or something like that. So we tried shooting in an oblique position also.
I don't know whether the view is there, but the heart looks humongous already. At least the previous cine you showed.
Yeah. Yeah, then I made the measurements. Yeah, flow volume measurements, and you find that the measurements were 2,500 and another one which was 2,700. So it looked like high flow. Now, what do I do with this? Whether I take it as predominantly a high flow fistula or the stenosis has to be tackled. But clinical examination later.
What stenosis are you talking about?
But didn't you, just beyond the subclavian?
Yes.
There is the.
But that I looked at that, but I thought it was the way you projected, because A, there are no collaterals, and B, the segment even distal to that or more central to the heart is also just as big. So I didn't think that was actually a stenosis there.
But the oblique shot, I couldn't. It wasn't through a sheath or a catheter which I couldn't use, because just with the fistula needle this was taken, thinking that after this I would do it in a later date. But then clinically, looking at it again, I find that there are collaterals, although in the angio there weren't any collaterals. So how do I go about?
Bala, what is the hand raising test in this case?
Arm elevation test.
Arm elevation test, yeah.
Proximal, difficult. Proximal fistulas, arm elevation, I know.
So in these people, arm elevation, the fistula will not collapse. What matters in these people is the thrill. If the thrill is continuous, there is no stenosis. So that's how we differentiate high flow fistula mimicking, obstruction. If there is an obstruction, then the diastolic component will disappear. You only feel a thrill in systole.
In case of stenosis with exuberant vein, how will the flow be? Will it be again more than 2,500 or 3,000, or it can't go beyond a level because there is effective constriction distally?
I don't know. If you're telling collaterals are there, they are maintaining the flow. So the fistula is trying to decompress. So those flows will continue to remain high when the collaterals develop, don't you think?
Yeah, if there is a stenosis, I think unless there are collaterals, you don't get that flow.
Right. That's exactly right. That's one of the caveats when you do the test to see, like you can get a continuous thrill in a patient with a stenosis. You're not expected to get a continuous thrill. But the presence of a continuous stool tells you that a collaterals are maintaining flow.
So from the presented angiogram, I didn't, you're not convinced about the stenosis because the distal flow beyond the.
Centrally, no. We have all seen how those collaterals will develop. I've not seen anything on this patient. So I find it very hard unless you can get me the two views. And that's one of the, rules. We should, or if you have something, you should get two views if you're not sure. So I understand what you're saying, but I'm thinking this is all high flow, in my opinion, just because I'm not seeing collaterals, but I could be wrong.
Yeah, and absence of collaterals, again, no indication for angioplasty because functionally there is nothing which is causing things. So even plasty is not indicated in this scenario, Bala sir.
Right.
Another thing is, irrespective of stenosis, like this patient will require flow reduction. That is for sure.
Right.
Absolutely.
You may, so you do flow reduction and subsequently you decide after say few weeks or few months that whether this patient requires venoplasty or not. But irrespective of that, flow reduction is definitely required according to
Yeah, I agree. And I'm looking at his arm, it's so thin, so I'm thinking he's cachectic. But that's my guess. And that's what the first thing you and I texted, how is the cephalic arch so big? I have never seen it. It is amazing. And so maybe he's just has no muscle and is just opening up.
Yes.
Adrian sir, we see a lot like that in our practice.
Really?
I will share in inform group. And second, should you do venogram to all these high outflow before intervention, or it is not?
I'm sorry, can you repeat the question?
All high flow fistula, before deciding the flow reduction, should we do venogram, like angio is a must?
Yeah, I think so. Yeah, you want to make sure there are no stenosis anywhere, right? Because two things can happen at the same time. Like you all just said, there can be collaterals developing and maintaining everything. So yeah, you would always want to do that.
In this patient, sir, did only with AV fistula needle. I think before planning a reduction, I think a detail angiogram of the
I
this
agree.
one
I think not just angiogram. I think I was just telling him, we need to look at his heart because if you're going to reduce, we just talked about
fraction. Yeah.
No, not ejection fraction. If it's low, it's low. What we're trying to pick up is high output cardiac failure, and the EF is always normal in a high output cardiac failure until it's very late. Then everybody can pick it up. And therefore, when you have high output failure, we don't go by echo, we go by right heart cath, calculating cardiac index and cardiac output. That is what is required. But as Dr. Rathi presented so well, if you're going to reduce, we have to be very mindful of complications in this patient. So we should not go blind. We should go look at the heart, look at all those things, and be prepared. What is his blood pressure on this guy, by the way?
It was 170 by 100. Manish, in your series, did all of them undergo regular angiogram before flow reduction?
Yeah. So actually what happened with these patients is they already came with angiogram. As I have shown, 60% of them had some sort of stenosis, not 100%, only 60% of them had stenosis. And 2 had repeated venoplasty and 4 had undergone venoplasty. So total 4 patients, 6 patients had associated stenosis, 4 had undergone venoplasty, and 2 of these 4 patients had twice venoplasty. And despite that, the symptoms were there persistent. So that is why then somebody actually sent them to us, and we assessed the flow and found a high output.
The other thing to do the fistulogram is, in the past they used to do the Miller procedure. Now we do all this, with the dilate and stuff like that. So one of the things that we would look for when we did the before we did the Miller procedure in the arteriogram is we would look at the diameter of the artery distal to the distal to the anastomosis, because when we band, we want to band to that diameter. So if the like Dr. Rathi, he's using a 10 or 12 French dilators. So 12 divided by 3, that means he's constricting it to 6 millimeters. So Miller would say we need to look at what is happening in the distal artery. But now when we use the dilator, we're not looking at the distal artery anymore. That's the other thing to remember.
Yeah, but that can be done by Doppler study prior.
Yeah, that's right. You can do an ultrasound and measure the distal artery. Absolutely right.
So I'll
But
do
pictures always make everything look beautiful.
So in this case, I think I'll do a regular angiogram with the sheath and things, or a CT angiogram, and come back to you to the inform WhatsApp group.
Sir, I think regular angiogram would be more helpful, sir. I'm a big fan of regular angiogram. CT angiogram only when we consider the recanalization or any sort of that, because regular angiogram is more physiological and also functionally significant.
Yeah, I'm not sure. I thought the cost for the CT would be higher than the regular angiogram. So here, at least with us, it's more expensive, I think. And the other thing, the only other reason if you want to do is if you're going to do a CT, because if you do not succeed in doing inflow reduction and you need the vascular surgeon, he would need the entire vasculature. Because, you know, when we are looking at a high flow fistula, you and I are only looking at the vein. We are forgetting about the artery. The artery is just as big as that vein or close to it. So there is arteriomegaly. And that arteriomegaly will cause a lot of complications. It can cause emboli to the distal hand, and you think this is steel. 2, because it is big, it can compress on the nerves and cause numbness and tingling, and you say this is steel. And you say the fistula caused the steel. But it is the big artery that is causing the problem. And so in this case, if you do that, you will get this entire study. Then when you want to show the surgeon, your vascular surgeon, even they can look and say, okay, you know, we have all the data we need.
Okay.
Okay, with the reason for the high flows, the one was the size of the incision in the artery. Why some of them develop steel and some of them develop high flow? Is there any explanation for that? When so much of blood is going back into the venous circulation, they don't develop, steel versus high flow.
The contribution of ulnar artery is important there.
So, a brachial fistula. So something more to the compliance of the vessel and some other factors are all playing, I think. It is.
No, you can have both the things together, like high flow as well as a steel in the same patient. But as you have said, it is to do with the compliance of the system more. And this is the one thing which is also very difficult to prove, that what is the compliance of the system and whether this compliance of the system is because of the high flow or the high flow is because of the compliance of the system.
Also, I think any correlation with the amount of peripheral vascular disease to the development of steel, sir?
That matters a lot. What in my experience?
Obviously.
A high flow fistula develops means the artery conduit is good, because to flow, to come to vein a blood flow, artery is dilating. Same thing happens distally also. That is why it is very rare to have a steel phenomena unless there is atherosclerotic disease or some chronic whatever process. I have not come across any steel phenomenon high outflow fistulas. I don't know about the literature, but what I assume physiology is when somebody is developing high outflow, means the artery is dilating and it is giving good flow to the vein. Means even the distal artery is same artery, unless there is a very, very, very bad. Like that is why the steel phenomenon is very common in venous hypertension is common in these patients. What I have seen.
Yes, sir.
I think that's a valid point.
The other thing we should not forget is the cardiac status. If the failure is setting in, then the perfusion of the arm is decreased. It will all go in the fistula. And so you can get ischemia. And then you mentioned everything else, diabetes, you mentioned atherosclerosis. And when you have a large arteriotomy, then, you know, the pressure head between the artery and the vein is lost because there's a big opening. So all the blood goes into the fistula, nothing goes down the arm. And that's how that large arteriotomy predisposes to steel.
Okay. I think we had a good discussion in spite of the initial glitches. Let me thank the chairpersons, the speakers, and all of those who joined in spite of change in the link and all that stuff. And nearly 30 people have remained till the end. So I think we'll stop here.
Yes, sir.
Say bye to everybody.
Happy New Year in advance to everyone. Thank you for such a wonderful session to close this year. Thank you, Manish sir. Thank you, Dr. Ajay Singh. Thank you, Adrian
Thank
sir.
you.
Thank you, Ravi sir.
Thank you. Happy New Year.
Everyone.
Yeah, Happy New Year to you. Right. I think this time I'll put the recording very early because some people interested might not have joined because of the change in link and things. I'll do that in the next few days. Thank you.
Thank you, everyone.
Thank you, sir.
Thank you.
Good night.
Good night.
Thank you. Bye. Happy New Year to you.
Thank you, sir.